So we're still assessing the nutritional statuses of our patients, and now we'll see the elective surgeries and the critical care. So we'll talk about nutrition in the elective surgeries, we'll talk about nutrition in the critical care scenario, and finally we'll talk about the methods which help us to measure the energy requirements in a critical care patient. So, talking about elective surgery, as the name implies, it's an elective procedure. So, you have a lot of time on your hands. You have prepared for it, you have longed for it, you have wanted it for some time now. You are prepared mentally and physically. The body is in optimum condition. You have timed it as per your convenience. So there are no stresses towards the body. The body is in optimum health, and these are the surgeries with the best outcomes. So the patients undergoing elective operations are adequately nourished. Obviously, they've planned them themselves, so they're adequately nourished. However, adding a 5% dextrose may be administered up to 5 to 7 days with no detrimental effects on the clinical outcomes. If there's slight malnourishment, you can add 5% dextrose for 5 to 7 days. It has not been associated with any detrimental effects on the clinical outcome, but the best possible scenario would be to advise the patient to increase the oral intake and to have the best nutritional state possible before the elective procedure. So, now in patients who present with evidence of starvation related malnutrition, now this is a different category altogether. So, in patients who come for elective surgery, there are all kinds of patients, and a few of them might be starving themselves to maintain themselves, or whatever the case might be. Now, this starvation may lead to chronic malnutrition in these patients. Now, in these patients, you need pre-operative addition of balanced macronutrients. So, when you come across a patient who has starved himself to malnutrition, you need to add macronutrients to the patient's diet. Now, you also need to add high protein supplementation, because this protein is required for the post-surgical period, when the new proteins would be required to by the new proteins would be built up by the body. It is initiated as far in advance as possible. The thing with nutrition is you cannot expect results in haste. So you should always prepare your patient well in advance. You should add the macronutrients, you should add the proteins to their diets well in advance, so that you can see the effects. The effects usually come in, the effects are usually seen within say 3 to 4 weeks at a minimum. So you need to add it in advance. The minimum time which is required to derive any benefit from this support is 2 to 4 weeks, as I've talked about before. Now, during this period, the electrolyte abnormalities are very important. They should be addressed, and there should be an early involvement of a nutritionist. It is always advised that for patients who have starved themselves to chronic malnutrition, a nutritionist should be advised, so that their caloric intake and the exact macronutrient required by them can be calculated and given to them. Now, keep moving on with the nutritional support in elective surgery. We know that bowel function returns within the first 5 to 7 post-operative days in majority of the surgical patients. Now, an oral diet or enteral feedings can be resumed once the bowel function has returned. Patients who are malnourished preoperatively or prolonged post-operative ileus is expected. They are unable to be fed enterally for 5 to 7 days. So in patients who are either malnourished before or were expected to have post-operative ileus for 5 to 7 days, it's impossible for them to be fed enterally for 5 to 7 days. In these patients, nutritional support is very important. Now, it's the importance is twofold. These patients are previously malnourished, and the stress of surgery. The surgery is a huge stress on the body. So, in order to maintain this stress, the nutritional support needs to be added to these patients. The nutritional status of the patient should be assessed as early as possible and with the help of a nutritionist. Now, enteral feedings are generally preferred to parenteral nutrition in these patients. However, the tolerance of the diet should be checked. So, enteral feeding is obviously always preferred, but some patients might not tolerate enteral feeding, so they might need parenteral nutrition. So, the standard high protein feeding formulas are usually adequate. Unless your nutritionist advises some other formula, the standard high protein formulas are usually adequate. There are three types of formulas for parenteral nutrition. Those which are simple broken down elements which are not digested. These elements are elements are given enterally and they're broken down by the body themselves. Then we have the broken down or pre-digested elements. These also contain whole grain, whole food. However, these are pre-digested. They're pre-digestive element that just need to be taken up or absorbed by the body. And then there are the macronutrient complement macronutrient diets, in which certain macronutrients are given specifically, and with those diets you can actually control the macronutrient you are giving to your patient. However, in this condition, in a patient who's malnourished or who's not tolerating enteral feeding, a standard high protein feeding formula is adequate. Now, the choice of product and the volume of feeding are they based on the results of the nutritional assessment. It's pretty obvious. In a very malnourished patient, you'll try to add high protein, high fiber diet, but in a moderately malnourished patient, you'll not do so. So that depends on the nutritional status of the patient, that you choose accordingly the product and the choice of feeding. Now, majority formulas, they're rich in water soluble dietary fiber, so that they can give you an element of satiety. The patient needs to have an element of satiety so that the patient does not have hunger pangs all the time. So the majority formulas are rich in water soluble dietary fiber. They also give bulk to the gut and form the bulk of the stool. It should be considered. They are considered standard in nutritional care of a surgical patient. Now, specific adjustments can be undertaken in special scenario. So, if there is a special condition, say the patient is allergic to something, or the patient does not tolerate lactose, the patient is lactose intolerant, the patient or some other dietary restriction, so specific adjustments can be made by the nutritionist. So the preoperative addition of a balanced macronutrient high protein supplement, it is useful to initiate as far as in advance of surgery as possible, and times needed to see the benefit. We've talked about this before. It's longer in severe malnourished patients. It usually is 2 to 4 weeks in normal patients, and in malnourished patients, it takes even longer. So you should start the nutrition well in advance. Now let's talk about the pre-operative total parenteral nutrition. So the preoperative TPN, the total parenteral nutrition, should be considered only to severely malnourished patients and only to those who cannot be fed via the enteral route. So the enteral route is the preferred route of administration of food. So if that route cannot be used, only then and in only severely malnourished patients, total parenteral nutrition should be considered. So it is an integral part of the metabolic care of critically ill patients. Now, this aggressive pursuit of target energy requirements is associated with optimal wound healing, recovery, and rehabilitation. So, the more aggressive your nutritional therapy is, the more optimal is the wound healing, the lesser is the recovery time, and the better is the rehabilitation, because the body has the energy and the guts to make or to construct whatever is required within it, because it is getting very good nutrition. So the good nutrition is an essential element to the recovery of the patient. Now, critically ill patients commonly have anorexia of disease. This anorexia can be adaptive or maladaptive. So having anorexia in chronically ill patients is very common, which can be adaptive or maladaptive. Now, in severe malnutrition in itself can complicate their course and it can affect the outcome very adversely. So, if a patient was already malnourished, now the patient has anorexia as well, and it is maladaptive, it would affect the outcome of the patient in a very bad way. So, starting nutrition early on before the surgery helps the body to prepare itself for the surgical stress. And once the body is prepared, the body adapts better to the surgical stress in itself. So, now, any critically ill patient who is not expected to resume an oral diet within 3 to 4 days should have nutritional support initiated as soon as technically and logistically feasible. This is pretty common in surgeries of the abdominal tract itself. Greater the manipulation of the abdominal tract, the greater the post-operative ileus, and as a result of which you should always start the nutrition as early as technically and logistically possible. It is ideally within the 24 to 48 hours after admission. Have their blood glucose level maintained at less than 140 milligram per deciliter. Now, the patients on enteral nutrition should have head of bed elevated to 45 degrees, so that aspiration, they might not aspirate the contents of the nutritional content into the tracheobronchial tree. Or they should be in steep reverse Trendelenburg position if the spinal precautions do not preclude this measure, so that they minimize the aspiration risk. So in order to minimize the aspiration risk, they should either be in reverse Trendelenburg, or they should be at a 45 degrees angle at the bed. So what are the methods to estimate the daily energy requirement? One of the methods is indirect calorimetry. Indirect calorimetry actually measures the oxygen consumed by the body during metabolism and the carbon dioxide exhaled by the body during metabolism. So for this, you need to measure the oxygen that is going in the body and the carbon dioxide that is getting out of the body. So indirect calorimetry can be seen in the figure. It is precise, but it's very impractical. It is not even, if not impossible, to apply in certain critically ill individuals. So it is not easy to apply. However, it is precise and helps you to measure the daily energy requirements in your patient. So this was all about this section. In this section, we talked about the energy requirements of the body. We saw how to manage the energy requirements, and what exactly is required, when to be added, what to be added, and how long to continue it. It's important to do it in that sequence because that is what will help your patient. For further sections, keep watching sqadia.com.